Good evening, everybody, and good morning for the few of you that are joining from India, that are very passionate about this subject and have joined us. If there is a subject that is ever worth being passionate about, it's this one. So glad that you're with us today, all of you, from whatever time zone you're joining in. My name is Sanjeev Joshipura, and I'm the Executive Director of Indiaspora. Really looking forward to this conversation today, and we have an entire team of colleagues at Indiaspora that is behind assembling this, who have done a lot of good work to make sure that we've gotten to this point on this program and various other things that Indiaspora does. After I introduce Indiaspora briefly, I'll be turning it over to the person who has been really the most responsible in her leadership role at Indiaspora in making this event happen. Shobha Vishwanathan is my colleague who lives just outside New York City. And she is our Vice President of Community Relations and leads our civic engagement portfolio as well. So I'll turn it over to her shortly after I introduce Indiaspora a little bit. Many of you know Indiaspora, of course, but for those of you that don't, we are a nonprofit organization that was founded in 2012, so we are 12 years old. And our mission is to inspire and position the global Indian diaspora to be a force for good and to build bridges among diaspora leaders across several countries and professions with leaders resident in India. Our vision is to be the Davos of the global India. In terms of who comprises Indiaspora, there are our invitation-only members. And the reason we are invitation-only for our membership is because we want to make sure we are inviting in our people, in our network, people of high accomplishment, as well as those who resonate with what we do, with our mission of being a force for good. So we want to make sure that people join us for the right kinds of reasons. And we are delighted, in fact, that our panel today has one of our premier members who you'll hear from later today, Nalini Saligram. In addition to our members, we have a fairly wide set of stakeholders who cut across various different professions, like I mentioned before, the corporate realm, the arts, academics, philanthropy, politics, sports, media, diplomacy, science, you name it. And all of these people are real leaders, trailblazers in their respective fields. And it's our privilege to be associated with them all. So that's who we are. But in terms of what we do, there are 4 specific areas that we focus on. One of them is philanthropy and social impact. We're a platform, a catalyst, a convener, an amplifier, a facilitator. And we work on social impact philanthropy, both from the perspective of working towards helping India, but also give where you live and help make society better where you live. The second area that we work on is entrepreneurship and innovation. The third is what we call Diaspora Next, which is our work with the next gen of the diaspora and making sure that their ties amongst each other, as well as with India, remain strong over the next several generations. And the last is our Global Connect program. So we're a team of 20 people that I have the privilege of working with every day across 5 countries, the United States, India, Australia, Singapore, and the UK. In addition to which we are extremely active in Canada and in the UAE and building bridges across various other countries. In fact, at one of our recent events in India, which was part of India's G20 presidency, there were diaspora leaders from 26 nations that attended. So building relationships slowly and gradually and steadily across the world. But really, that is Indiaspora in a very brief nutshell. What I want to do is really keep the focus on the event today, on this vitally important subject that, as some of us were discussing before many of you joined in sort of our pre-preparatory call, it's 2024 and now we are shining a light on it, which is great. But what were we doing in the past? Why is it only now? But it's great that we are at least talking about this today. And no one better to talk about it a little bit more about our event today, about our civic engagement work than our senior leadership team member, Shobha Vishwanathan.
Thank you, Sanjeev. Sanjeev has really laid the platform for why we do what we do here at Indiaspora. And one of the joys of building the community that we build is meeting people who are leaders in so many different sectors. So when we decide on any given topic, we just have to cast a net to find who is doing work here and find multi-sector representatives who are truly leaders in every aspect of this work, which is what we have tried to assemble today on the women's health subject matter. Why did we arrive at women's health as a topic? I think it first caught our attention when the White House initiative on women's health was announced last November. And as is true of many things, once a topic enters your head, you start noticing more and more references to it. And it seemed almost inevitable that we would keep running into articles about it. And then there was a McKinsey article which made the point about the economic impact of the gap in the gender gap in health concerns. And so again, another reinforcement of the idea of why we need to spotlight this. And I think Amita was the one who found the Forbes article, which said that this is going to be the year of women's health. So it seemed like a no-brainer that we should make it a point of importance for this March conversation, that we try and have some conversation on a women's issue. I hesitate to use that term because it's become a token, but that's not the idea here. We are thinking of the Indiaspora platform, the virtual platform, as a good way to have a public conversation on a very, very critically important issue. And we are very grateful for each of our panel members who have given the time to be part of our conversation today. They truly bring very different sector lenses to this conversation, and we think will create a valuable intersection of ideas, and we are excited to see them share their perspectives. Our four panelists are Smriti Kripanandan, Amita Vyas, Dr. Shyam Kotalil, and Indiaspora's member here, who is Dr. Nalini Saligram. I'm going to introduce Smriti and then leave it up to you to take it forward as the moderator and speaker. Smriti. Smriti is managing director at Accenture and works on healthcare issues, but that's only the last of her titles. She has a very impressive resume and has been working on public health related issues for a long time. Very recently, she was at Davos as a leader there representing the conversation from her perspective in a different context. So Smriti, over to you, and we look forward to this conversation.
Thank you, Shobha. Wonderful to meet you all. Good morning, afternoon, evening. Would like to extend the gratitude to Indiaspora leadership for holding this space for this important conversation. As Shobha mentioned, my name is Smriti Simi. Background has been in robotics, public health, been in the health wellness field for around 15 years. I'm also a chef and nutritionist, so you can really think about the eclectic intersection I bring here. But I would love to introduce our panelists here. I would love for them to make the self-introductions. Amita Vyas, off to you first.
Thank you, Smriti, and it's truly a pleasure to be here with all of you, and a special thanks to Indiaspora for highlighting such an important topic. I'm Dr. Amita Vyas, and I'm a professor at George Washington University at the Milken Institute School of Public Health, where I also direct our Center of Excellence in Maternal and Child Health. All of my work over the last almost 2 decades now has really spanned, adolescent, women's, and maternal health, both here in the United States as well as around the world. And of course, I really take a public health perspective in designing interventions and testing interventions to hope that we can scale and sustain those and really change policies as we think about investments in women's health. And, I'm just personally incredibly passionate about the issue, and I believe that investing in women's health is really the smartest investment opportunity of our time.
Thanks, Amita. The smartest thing to do and the right thing to do. Next, Shyam, please.
Thank you, Smriti. First of all, let me thank Indiaspora for inviting me to be this panelist. It's really a privilege and an honor to be along with the lead panelists who have done so much for women's health. I'm a professor of medicine at the University of Maryland and chief of Institute of Human Virology. I'm an infectious disease doctor by training. And most of them, I'm chief of infectious disease at the University of Maryland. And along with others, I'm really glad to speak about the disparities in gender and hopefully find solutions. Thank you.
Thanks, Shyam. Nalini?
I'm Nalini Saligram. I'm the founder and CEO of Arogya World. We do diabetes prevention through healthy living in India. And we've reached about 12.5 million people using what we call a doorstep health model, taking prevention to people where they live, learn, and work. In recent times, we have just been inducted into the Million Lives Collective. So we work at the base of the pyramid. We also work in urban settings. And we have reached 12.5 million people in India with our diabetes prevention programs. I do want to say that in women's health, our interest is in sort of a 10,000 women study that we did, as well as using women as a solution to the non-communicable disease crisis that faces our generation, and which is threatening the world meeting the Sustainable Development Goal, at least number 3. Look forward to this conversation.
Thanks, Nalini. Well, let's deep dive right in. Obviously, we're here because there are disparities. Women's health is taking a back seat. So the first question really is, how do we ensure that diverse perspectives and voices from different backgrounds are represented in conversation around women's health? Let's start with Shyam.
Yeah, thank you, Smriti. So I guess, when we address disparities, first of all, we know the things we know. There are a lot of things we don't know. There are a few things we know, that there are health disparities do exist and the gender gap does happen. And there are diseases that predominantly affect women. However, that's only a small fraction of things. There are a lot of things which actually do not know. And we have to think why we are not able to understand a bit more. So things we know, for example, autoimmune diseases occur in women a lot. And when you get pregnant, many of these diseases actually do get better. Some actually do not. And so it's not an easy answer that we understand the biological significance of those things. And that will take time. Understanding biologically why these things happen is important to understand. And it'll usually take a long time to understand. However, there are things we can actually do. The awareness of the disease process to the consumer, which is like women, and also to other people in the public health sector, as well as people and providers who actually take that into consideration when they manage or screen patients or increase awareness. That's particularly important. One of the major reasons we actually did not get a lot of information is because we did not include women in our clinical trials. So we didn't have any. In 1973, there was an FDA act that said that participation of women in the reproductive health was banned. It was not allowed. They were more concerned about the safety of somehow people could be pregnant than the safety of the baby, etc. However, it took 10 years, and the US PA just said that this is extremely detrimental to understanding women disparities in the health that can happen. And it took Florence Hasseltine and other people who pioneered policy changes in participation of women in the NIH. And it took almost 1993, 20 years later, the FDA reversed that act, actually. So it took 20 years, but it did change that. And that like about 6-7 years ago, NIH has now said that not only gender disparities, minorities, as well as all sort of different sectors have to be adequately represented before these medications are approved from that. So those are steps, slowly but steadily, has impacted our understanding of the disease process. So I think that's an important part of it. And lastly, I would say that, if you look at diseases, like example, migraine, a simple thing that affects women a lot than men. The total NIH funding for migraine is $13 million. And if you look at funding for HIV and AIDS, it's $3.6 billion. I'm not saying that we should spend all HIV money on migraine research, but I'm sure there has to be that thought process and lobbying. These things only happen by constant lobbying, by all advocacy groups, so that we can really understand the problem and then try to solve the problem.
Thanks, Shyam. I think you brought up some 3 important points, right? One is equity at the beginning, right? Not at the end. It's not a reactive situation. It's a proactive situation. How do we place women in clinical trials? And I think Biden's $100 million funding really reflects that. I know it's 2024, pretty perhaps late, but I think that's an important point that we're at least doing it now. And secondly, I think it's really, how do we start having the conversations around disease and repurposing budgets and then really using them for the right things at the right time. So I'd love for Nalini to kind of reflect on that, and then Amita.
Yeah, so for me, what is most refreshing about the White House initiative is that finally in 2023, 2024, we are thinking of women's health in a holistic way and caring for women's health across the lifespan and across the life course. So a woman is more than her reproductive years, right? I mean, a woman has a right to health from the day she's born through her 5th birthday, through adolescence, through reproductive years, as well as her old age. So it's very wonderful to see that the emphasis is on not just that sexual and reproductive health. In fact, that aspect, sexual and reproductive health, as well as maternal and child health, is only 5% of the disease burden of women's health today, at least from this paper that was circulated, the McKinsey report. I also want to say that we did a 10,000 women study in 10 different countries. We asked 1,000 women in each country what they thought of was the impact of these non-communicable diseases like heart disease and diabetes and chronic lung diseases and cancer. How do they live with it, and what is the impact on their daily lives? And we were surprised to find out that, first of all, 2 out of 3 women said someone in their home had an NCD, and 50% said they had to care for that person with the non-communicable disease, and 20% had to quit their jobs to do so. So this unpaid care is a social issue that must be taken care of in this health context, right? And 25% of the women told us that they spend 25% of the family's income on that one person's health. Okay, so this kind of stuff is untenable and is not sustainable, and we really have to come up with solutions. And the only one other point I want to bring up, and that is old age. Women outlive men. And in their old age, when their bodies are frail and their chronic diseases are, affecting them in big ways, that's when loneliness is also a very big part of the equation. So when you look at women, you must look at lots and lots of social contexts as well.
I love that you brought all the numbers, Nalini, but I don't love the numbers, but I love that you brought the numbers. I know you touched a little bit on maternal health. In the United States, we are in a maternal health crisis, right? Like the mortality rates have really gone up. Amit, I would love for your insights and lean in on just this topic, including the maternal health piece.
Yeah, thank you, Smriti. I mean, I love what the other panelists had, shared, and Shyam really talked about some of the biological and physiological differences when we think about women and, the unique context of women. And we also have to remember, right, that women live and work in a different context than men. And, so much of the health inequities that we see in our data, in the real world through stories and women's lived experiences, we know that it's really rooted in gender inequities, right? And so if we're really going to flourish in terms of changes in policies and interventions that are effective on the ground, it's going to be incredibly important that we really create a new normal for girls and women, right? We have to address the gender discrimination, the patriarchy, gender norms, if we're truly going to address women's health issues. And when we look specifically at maternal, and child health, and particularly maternal health here in the United States, which, we all know, I'm sure everybody's, read the stories of, how maternal health continues to be a crisis in the United States. We have the highest rate among all high-income industrialized nations, right? It's truly shameful, given that we spend more on health per capita than any other country. And yet maternal health it's a crisis, and it's fully preventable in this country. So we need to think about the racial disparities, right? So we know a lot of that is really embedded in some of the sort of structural racism and systematic biases in our healthcare settings. Women need to be heard. Women need to have respectful healthcare. We often have providers that make assumptions about women, particularly women of color. Women need access to care, right? And it's not just health insurance in terms of access to care. Right here in the nation's capital in Washington, D.C., we have maternity care deserts. We have entire regions of our district where we don't have maternity care for women, and where we have women who are delayed in even accessing prenatal care into their second and maybe even their third trimester. And to what Nalini was talking about, certainly women are not just about their reproductive health, right? We really need to consider the intersection of reproductive health and chronic diseases. And we've seen increases in type 2 diabetes, in hypertension, and all of these are really exacerbated in the perinatal health phase, right? So again, increases risk for women is what we're seeing. And then I think the newest area that we need to spend a lot more time in is what we call the 4th trimester of pregnancy. And that's really in that postpartum period. And what we've seen is that it's almost as if care completely stops for women after they give birth. And yet it is in that postpartum period that we see incredibly high risks for women, whether it's maternal morbidity and, other, maternal health issues or actual maternal deaths. And so thinking about things like mental health and women's ability to access mental health care in that postpartum period, social support, again, going back to what Nalini said about loneliness in some of our elderly, an aging population of women. We also need to think about that sort of loneliness in that postpartum period. And so we're only now really beginning to understand both mental health in the postpartum period, but also thinking about how can we design programs that really get at the entire well-being of women, both physical and mental health, where we are addressing chronic health and addressing women across, before they're pregnant, during pregnancy, and after pregnancy as well.
The real ask here is, how do we have a full 360-degree honest view, not just a view, an honest view of women's health? And how do we actually amend, bend some of the policies, the rules we have in workplace and personal space, and really make those changes, right? From a business stakeholdership, from a patient experience, and also from a policy perspective. Teeing up to this is obviously the question of equity, which I'm most passionate about and fight for. What are the key barriers to achieving gender equity in healthcare and access to quality women's health services? And how do we educate and create awareness campaigns to really promote this healthy lifestyles? And really the ask here is, yes, health is, sometimes generalized for men and women, but obviously women have a different experience, right? This is not about creating different different experience, but I think it really is about what do women experience from the time they're young to their teens to when they become, young people living, they work. I mean, think about me living in Los Angeles, right? I have a whole different experience than someone as a woman living in India who has a complete community support, a complete patient support. So how do we really address that? Plus, how do we actually make it equitable and, break down the barriers? Amita, let's start with you.
Yeah, I mean, I think it's exactly what you said, right? We have to address the whole of a woman, right? And we have to think very comprehensively about our health. And so 2 things that I think in terms of solutions. One is workforce development. We need more women in the women's health workforce, right? We need women in public health. We need women as community health workers. We need women as doulas. We need women providing care to women across their entire lifespan. So I think that that's one piece of it. The second piece of it is we truly need to change the hearts and minds of people in terms of how we value girls and women and how we value their health. We often even, in sort of the education space, we try to address a lot of the issues with sort of structural, interventions and policies. Okay, if we build more schools, more girls will be educated. If we can build more health centers, more women will have access, right, to healthcare. But if we don't actually change the way people value, right, girls and women, they won't be able to access any of those services. And so, one of the things you said around, campaigns, I do think we need to do a better job of changing gender norms through really innovative messaging and media campaigns that, again, really change the hearts and minds of how we value girls and women. And then the second piece of this that I think is a really important thing to bring up that I often don't think gets talked about as much when we talk about women's health is gender-based violence. So in some of the work that I've done here in the United States, focused on South Asian American women, we have found incredibly high rates. And I think most of you, would know this already in some of the research that you've read around intimate partner violence and gender-based violence. In a recent study that we just conducted with about 2,500 South Asian American women in the United States, we found that almost 66% of women had reported some form of intimate partner violence in their lifetime. And almost 20% had been diagnosed with type 2 diabetes. And when we ran some of our models looking at the data, we found a strong association between intimate partner violence and type 2 diabetes. right? So there is this link between sort of exposure to violence, right? Whether it's during childhood or during adulthood, and chronic disease later in life. So intimate partner violence is not something that affects women physically and mentally at one moment in time, but it really has long-term impact, including impact on increasing their risk around chronic disease, right? Violence increases stress, increases cortisol levels, increases mental health issues, such as depression and anxiety, which can affect, your eating, your sleep, your exercise, right? And all of those we know are risk factors for chronic disease. So, as we think holistically and comprehensively about women, I think it's very important that we think about violence and it's the long-term impact that violence has for women across their life course.
Thanks, Amita. Again, more numbers, love numbers, but don't like these numbers, right? I think one key thing you really are asking for is a mindset change, right? Beyond when we go to technology and policy and everything else. Historically, that's been a problem. I think we made some improvements, still miles to go. And next thing, Nalini, what you mentioned about the isolation, depression part, in the US itself, 50% of them are rated to be experiencing depression, anxiety. That's a high mark, right? And given women, the hormones, the aging crisis we have, which by 2050, most of us will be about the age of 65, which is absolutely, crazy to hear that. But that's where we are, right, in the benchmarking metrics. But Nalini, would love for you to lean in on your perspectives on the same question.
Yeah, so, Amita, I found that fascinating. I didn't know these links, so I'm intrigued. I have a PhD in biochemistry, so my mind is now trying to find out. I've got to read up on all this. But anyway, so one other mindset shift, that we all have to accept as women, women put themselves last. It's the child first, the husband, and then last. In our 10,000 women study, the 1/3 of the women in 10 countries, rich, poor, countries, told us they had never had a simple blood pressure test all these years. They've never had a blood pressure test. Okay, so how are we going to, they have to put themselves first. And at Arogya World, we look at women as a solution to the NCD crisis. In fact, we know that unhealthy eating is the #1 cause of death. It's the #1 reason why diabetes exists in such high numbers in India. And we've taken it on as a challenge. We're only 24 people, but we've taken it on to shape the way India eats. So we have used social media to educate urban women on what to eat and in what quantities at every meal. We created a tool called My Thali, according to the National Institute of Nutrition guidelines, and we are promoting it and educating millions of women. And we have worked with Nielsen to figure out what exactly we've done, to change their hearts about what they should be eating and what their husbands and sons and daughters should be eating. And we have found 2 million of the women we have actually engaged with over these 3-4 years. So we did we know that 1,000 women die from heart disease every year. And so that's another thing we have taken on. And we want to shine the spotlight on women's heart health. And we do that every March. And we just finished a red sari challenge. 500 women ran in red saris in Bangalore, and it's really a fascinating sight. So we are doing what we can to educate women about health issues that affect them and their families. And we want them to become change makers and steer their own families towards healthy living, because then I think the rest of the society and country can follow.
Thanks, Nalini. I think you're calling out two important things, right? One is women are generally beyond or are beyond their uterus. And secondly is really how do we be a little bit more selfish, which I think is maybe a cultural problem, maybe not, I don't know. I'm not a psychologist here, but I think two key pointers over here. Shyam, would love for you to lean in on the same topic.
Sure. Thank you, Smriti. So I think great points when brought up, both Amita and Nalini. And I think, one of the things that Amita mentioned about having more women in workplace and be able to tackle the problem. And one of the challenges we understood from COVID is that our work is related to daycare. And COVID kind of exposed who takes care of kids, which gender takes care of kids, right? So that's pretty clear. And that was really very difficult for one part of our group to come and work during the COVID time. And it is unfortunate that we are a very developed country. We still don't have universal daycare system that we can actually, come to work. And that's a big challenge. Things like that, I know we have to be able to tackle. We have to be able to tackle, free up people so they can come and disassociate work versus life, so they can concentrate on part of it. I just give you some examples from our lifetime. So human papillomavirus vaccine is 100% protective from cervical vaccine. The uptake of that vaccine in Baltimore, young children, especially girls, is less than 10%. And that's because just don't. This is the remedy like blood pressure. Nalini brought up blood pressure, like simple things that you can know that it's a remedy. It's actually not. Why doesn't it happen? It's because of trust issues. They don't have that trust establishment, whether it is gender-based trust or is it a race-based trust. In places like, there are predominantly, Black communities in cities, they really have distrust from providers, even though they belong to great institutions, they have that trust issues not built up. One of the things that worked in our field in HIV as a chronic disease model is the peer-to-peer navigation. You have, like Amida brought up this thing, we really need women who can talk about these conditions and a group, and then that's very much more effective than someone who's so-called expert, talking about things. So I think that those are the type of solutions that have been applied in different things. We have to start more generalizing to all our global population and try to solve these issues.
Thanks, Sham. Even at Accenture, yeah, go ahead.
Can I jump in on something that Sham said, because I thought it was fascinating? And I think the HPV vaccine is a great example of one of the first times sort of in recent years where we saw the effect of misinformation and disinformation, right? And this is probably pre-social media, which has really exploded the field of mis and disinformation. And sort of now what we see is so much misinformation out there, particularly for adolescent girls and women, right? When we think about issues around family planning and contraceptive methods, the COVID vaccine, certainly we saw that. And so it's not just finding sort of trusted healthcare providers and trusting the healthcare system, which has been institutionally very biased in so many ways, but it's also just finding other ways of information that's credible and trusted as well. And I think in public health, one of probably the biggest challenge we are going to face in the next, decade at least, particularly with the explosion of AI, is combating misinformation and disinformation about health issues.
Yeah, no, I think very accurate, Amita. I think, even at Accenture, what we're looking at, some of the blockers, right? Like what creates disparities? It's implicit bias, it's racism in clinical trials, it's richly systemic structural changes that needs to be put in place. But, the Google Health recently released an article about how information is a determinant of health, right? The lack of proper information also causes a lot of confusion, biases, disparities. So really placing responsibility, equity, and also empathy, whether it's technology, policy, clinical trials, I think is really key. The next question, which I think...
Sorry, before you go there, I just wanted to pick up on what Sham had said about workplace work. So it's very interesting. Yes, COVID has changed a lot of things about the way we work, and women's participation in the labor force is actually something which is alarming in India. It is very low. It is declining. So it was World Bank says it was 32% in 2005 and 19% in 2021. And we are lower, India is lower than Afghanistan in workforce participation for women. So something has to be done, okay? And at the core of it is probably that care, childcare, and people got used to it, and to some degree also prosperity. And there may be several other reasons why, but let's not go there. I don't want to comment though. I watch my daughter, who has a 1-year-old baby girl, and she is struggling with this here in the United States. Care, young mothers have so much thrown at them, and they've got to juggle so much. They are still executives. They show up at work. They have to be present at work meetings. But at the same time, if someone could give them 5 minutes between meetings, to go check on that child. Yes, there is a nanny or somebody watching that baby, but still it would be so good if the workplace would understand that a 5 minute, instead of making the meetings 1 hour long, you make them 50 or 55 minutes long, just to give somebody a breather to go check on this. And also her workplace, she works for a tech company in the Bay Area, they give her backup care. So it's not just she pays for her nanny, but in case the nanny can't come, she actually, wherever in the country she is, she can access backup care. These things increase loyalty far more than, compensation and other ways of incenting people. Caring, showing to women that you care for them and women employees goes a long way.
I love that you mentioned that, Nalini, because I think what you're really asking for is dignity, respect, and really a sense of belonging, right, with every organization. And I know where I work at Accenture, we have a complete backup support, in terms of daycare, in terms of fertility treatments, so it's completely understood. It's just amazing that you brought up that example. I think it's key. There was a graph, Shobha, we may have to find this graph, which showed that how men's career trajectory versus women, men's, it goes up, and women just like scales down at age 30 and goes on till 48. And then, we try to pick it up and it actually never picks up. So the next question, which I think would take up the rest of our time, is really how has the COVID-19 pandemic impacted women's participation in the workforce, which we kind of touched based on, and what strategies can be implemented to support women's economic empowerment and work-life balance, considering the intersections between women's health and also the global issues such as climate change, gender-based violence, and economic empowerment as a whole. So we're just wrapping it all up. Amita, would you like to go first again?
Yeah, sure. Absolutely. Thanks. So, I think it goes back to what we've all touched upon over the last, 40 minutes or so, which is treating the whole of a woman, right? So in order for a woman to be successful and to sustain herself in the workforce and to become economically empowered, she needs to be educated. She needs to be healthy. She needs to be free from violence and safe at home, safe going to work, safe in the workplace. And she needs to be able to have access to training, mentorship, technology, and financial resources. And the reality is, right, that is a lot, right? But if we're really going to lift women up, we need to address all of those issues. And traditionally, right, if you think about education and health and livelihoods and gender-based violence, we all tend to work in our own silos, right? We're singularly focused on our one issue, right? So folks, in sort of maybe the banking sector, for example, who are really interested in providing financial literacy and financial inclusion and other financial resources and training for women, they're working in sort of one area of a woman's life. And separately are those of us who are perhaps working in areas of menstrual health and hygiene, family planning, nutrition. Over 50% of women are anemic in India. How can we expect them to work, right? I mean, that's $1 billion loss a year when women can't work due to anemia. And so really, I think in the best scenario and where we really need to be moving forward is to have, really co-create and collaborate across different sectors to provide multiple levels of interventions for women, and particularly to provide these interventions for women in the workplace, right? Provide the training that she needs, provide the health resources and education that she needs, and to ensure and institute policies that allow her to care for her children, to care for elderly and aging parents, which also falls, right, on women's shoulders, and policies that will ensure her safety to work and her safety at the workplace itself. And until we can assure all of those pieces, there's truly no incentive, right, for women to stay in the workforce. In fact, it's completely disincentivizing women to stay in the workforce. So again, I think we often focus on, yes, how do we ensure women's economic empowerment? It's all about access to technology or financial resources, but it's so much more than that in terms of what the barriers are for women.
Amita, I think you hit a nail that, we are doing it all, right? We are struggling in some ways. We give birth, we take care of kids, we come home, and we're working, right, in the boardroom till making coffee to cleaning. So do men, not discounting you, Sham, and every other one listening in. But I think it's truly is, if you want us to show up, at really a high potential and honesty, then we need the full 360-degree support, and there's no other way to do it, right? Sham, would love for y'all lean in. Actually, y'all lean in two perspectives, one for women, and as men, what would you request men to change and mend, right? I'm not saying they're doing anything wrong. I'm just saying, what would the ask be to make us feel more belonged? And yeah, what would your perspective would be?
Yeah, and so I think, let me just take and continue from what Amita said, from what COVID said, a lot of the problems with COVID presented for us was the preventive care part of it, right? That's where we fell apart with all the lockdowns and everything else. And now we are learning that all those things that you were supposed to do, we didn't do. And now we're discussing finding out cancers later, etc. So women, a lot of the women's healthcare is preventive care, and that's been there, and that's all been completely messed up by the pandemic, and it takes years for us to recover from that. So what we learn from that is that we have to think about in a variety ways we can actually link people, the co-location of care. Like we not ask people to go and see an OBGYN one day and then you go and see a heart specialist another day, and that just doesn't work, right? Because that's just not, it's not something that people have the time, especially if you're juggling so many different things. It's not possible for us to do. So there are the great healthcare models for this, vertical healthcare models that which HIV cares that we done in Africa quite successfully, but it's only for one disease. There is a horizontal healthcare model, which looks at primary care perspective. And what you really need is a diagonal model, which is you can adapt, and the doctor can actually adapt and take care of the wholesale problems. If you find things, you don't have to go to another. So I think simplifying all these models do exist. To correct that, that helps with the increasing awareness and engagement of care in women. So the question, what men can do? So we have to look at the perspective. Things have changed in medicine. 70% of medical students are women. The healthcare sector is completely changing. I know, I understand that a lot of the people on the top are still men, but it's only a matter of time. We will have women leadership coming in, and most of the things will be changed from a different perspective part of it. What men do is to be able to not see from our own perspective, and to see from the other perspective. I usually tell people, if you have a daughter, it's great, then you see things from a different perspective. So that is something that you can understand. And many of the things, with a lot of the problems in workplace system, you guys work in great companies in Silicon Valley, right? But they are not necessarily true in all part of the United States, right? You don't get those kind of perks that you do get it, because most of these are made by men who didn't really do any of those things. So they didn't see those were chores for them. And so that's what's changing now. I think, that's something, those things have to change, and we have to see how we can make, both groups work better. So we can, look things from a holistic perspective. Both groups are actually taken care of.
Yeah, so I'm hoping not all men need to have girl kids to realize this, but I hope we are better than that as humanity. But really, I think one-stop shop, right, to get access to all kinds of care, a 360-degree, whether it's blood pressure, diabetes, a pap smear, I think it's key. And also subsidizing the cost of care is really key, right? I mean, we're not just talking United States, but across the globe. Even having access to internet is critical. Like, a lot of women don't have access to internet. We think about farmers, everybody else. There is a lot of data which shows that climate change is now showcasing how women show up to work, how women react, how premenopause is really being accelerated to a higher rate. So there's a lot of intersections we're seeing. Nalini, would love your viewpoint on the same question and how the implications are playing out.
So I'm going to probably interpret this differently. I'm also looking at the time. I am really very happy that in the White House initiative is treating is prioritizing health across the life course of a woman and is thinking of women's health in a holistic way. It's really refreshing. It's very exciting to see that. In fact, 6,000 women, US women, enter menopause every day. And it's good to see menopause as a research topic. I saw that in one of their write-ups. This is really good. It's very good. I'm very happy. So if I had to give advice to the White House, on what they should prioritize for research, for me, and we do diabetes prevention, so I always think of the angle from diabetes perspective. For me, the key area that a stage that we should intervene and understand is the adolescent girl. The girl before she gets pregnant, before she gets married. If she has good health and good nutrition, not only anemia, not just looking at India, but not just anemia, but also she'll set herself up for a healthy, safe pregnancy, have a normal birth weight baby. We didn't cover low birth weight today. So normal birth weight baby is critical, because if she has a low birth weight baby and then everybody around her, the grandmother, fattens up that baby 30 years later is going to have a higher risk for diabetes and heart disease. So the best leg up she can give for her child is to have a normal birth weight baby. So who is the best target for intervention, for public health interventions, for education, and for real health promotion? It is that adolescent girl. So I'd love for more research and more clarity on that, and finding pre-diabetics and understanding what exact interventions will work to prevent them from becoming diabetics. Those are the sort of key things. The other one I would really love to see is more research on mental health, because two to three times higher anxiety and depression are there in women than in men. So it would be really good if the White House research agenda tackled that.
Well, if someone from the White House is live listening, then I believe you have our requests. But I know we are close to time, and we would love to open up the floor for some Q&A. Shobha, if you'd like to orchestrate that.
Thank you. Fabulous conversation as expected, and just what we needed, the multiple perspectives. Our faith in public conversations is reinforced each time we bring folks together and say, hey, talk about the things that you care about. And the intersection, when Nalini reacted to the point Amita made and the articles that were shared here, this is what we want from these conversations. Smriti, beautifully moderated. Thank you all, Sham. Really good contribution. One of the questions that came up on the side, and if Anjana is available and willing to come on camera, we'd love for her to come ask this question. Is Anjana, are you available?
I am.
Thank you. Would you like to ask your question, please?
Thank you so much. That was so interesting. So this is about the research you shared, Dr. Vyas, about the correlation between violence experienced and leading to diseases like diabetes. So I was wondering if this is a reason for children to also develop it because of the violence they faced or saw in their childhoods.
Yeah, absolutely. That's a really good question. We didn't look specifically at chronic disease, but we did publish a study a few years ago, again, focused on South Asian American women here in the United States. And we did find incredibly high rates of childhood exposure to violence. So either, witnessing parental violence or childhood, violence themselves, mental violence, physical and sexual violence as well. But we weren't able to look sort of across into adulthood, diagnoses of diabetes, but certainly, the life course theory is something that many people have researched and tested over time. And so there really is the assumption that it's not just violence in adulthood, but exposure to violence even as children that can have sort of long-term, impact in terms of chronic disease. So again, what, Nalini's been really talking about the life course, it's even thinking about the fetal origins, right? And intergenerational trauma, right, can influence chronic disease, not just for yourself, but for your children, right? For your children that might be born later in 30 years. So it's, we really need to prevent violence for sure, but we also need to be thinking about how we can mitigate the risks of chronic disease and other mental and physical harms associated with with violence.
Thank you.
While waiting for other questions, I did have one. This came up, I think Sham was the one who said that women should speak up and speak up about their issues themselves rather than have experts be the ones who make the point. And I think it was in the news a couple of years ago when Serena Williams went through post-delivery issues, and somebody of her stature and unquestionable self-confidence still found it quite challenging to navigate her advocacy. And I thought that was rather eye-opening in terms of how intimidated we are in certain settings to speak up for ourselves. So do you have any suggestions on what should be our skill sets we should develop? How much should we trust our instincts? How much should we go with what is told as given wisdom? I know we don't have prescriptive answers for these things, but I would like some suggestions from you on how we should approach this matter of conversations with medical experts.
So, diseases are always stigmatized, and history of medicine tells you that everywhere we have had problems, right from, the HIV pandemic was the same, opioid use pandemic is the same. And, we have a lot of celebrities who suffer from both. And we just didn't, we shunned them, and we really didn't. So that's why made it very difficult for people to come in. And we also are judgmental than how you get it. For Magic Johnson got it the funny way, and Arthur Ashe got through transfusion. So there were two different, moral and ethical standards for that for people. So these things do happen, and for any disease patterns actually do happen. But I think that's what happened, and there are a lot and more. And I see that in India there are a lot of celebrity women actually coming out and talking about mental health issues, and that's really courageous and actually the most useful to understand. If you look at the statistics, my daughter goes to in this college, and she comes back and said many of the students actually are receiving mental health counseling and medications and for treatment for that to cope up with the competitions and tough things that happen. So this is really reality that these things do exist, and people have to speak up so they actually can go in and seek that help. So I think that's a good trend that people saying that we cannot expect people to just agree with us all the time. It takes time. And that's why these people are courageous, that they actually come back and talk about their issues, most difficult thing for the betterment of humanity.
Yeah. And
Can I add to that, Shobha? Because I think that was a really excellent question. And I absolutely agree with you. Women, we need to be building women's agency and voice to speak up. And I think we're seeing much more of that. But, when you think about sort of Serena Williams and many other celebrities, particularly, again, women of color, the big thing here is that there is really this institutional racism and systemic bias in our healthcare system and in the healthcare setting. And one of the things that you will repeatedly hear, and that we've heard right here in Washington in the work that we've done around maternal health, is how their voices are not listened to. Providers are not listening to them. Providers have an implicit bias around, how they interact with women who are coming in, who are saying, hey, I'm actually really not feeling well and something's not right. And, providers often make sort of judgments around pain tolerance that a certain type of woman might have, right? So the real solution, while yes, we want women to have agency and voice, and we want them to be powerful and to transform the health system, but the real solution is transforming the health system. And we need to make sure that we're training women from those communities who can become providers of care for women who look like them and who can understand them.
And I think I'll add, right? I think this is also beyond a healthcare wall between, a kind of an issue, because this is more of a community issue, right? Whether it's Serena Williams, yes or no, I think end of the day, we are humans, you're women. There should be a culture and a community where there's no shaming done, right? We all have different problems, whether said or unsaid. I think it's really a community ecosystem problem where we appreciate and respect each other's issues and really come forth with support. And that also, healthcare is a big part in that as well.
So, Shobha, I
Yes.
wanted to add just a
Of course,
slightly different perspective. So, in what we find is that in workplaces can play a big role in normalizing mental health and, making it okay to talk about it. So we have in India, for example, we have a very big program, Arogya World program called Healthy Workplace. We've recognized 215 companies as healthy workplaces if they meet certain physical health and mental health criteria. So in COVID times, we added mental health criteria. So we now require companies to comprehensively meet criteria, and several of them are to do with stigma, destigmatization, awareness campaigns, making it okay, getting the boss to be a role model, as well as supporting the employees, and not blocking their career progression if they come out and say, I'm suffering from schizophrenia. So there are many, many really good examples that my colleagues have in India of mental health at the workplace, and culture change, becoming data-driven around health, both physical health and mental health, so that the workplace changes. If the workplace culture changes, lots of things will change in society.
Thank you all for your interesting points on this one. I know my colleague Amita had a question. Anjana has also asked a question, which may be a nice way to round out the conversation about if you could pick one topic you want to highlight. We'll leave that as the final one to close out. Amita, do you want to jump in with your question?
Yeah, actually, in our pre-call, Dr. Sham had actually said one thing that has stuck in my head since we had the pre-call. He said that women die of heart disease with normal biomarkers. And that was really, interesting, and it has stuck with me because every time you go to the doctor, one time I had a tummy upset, I went to the ER. The first thing they did was, check the troponin or whatever, like some kind of cardiac markers. And they were like, it's normal. And then when I heard about what you said, and you said it's because there's not enough data about women. So I wanted to ask you more about that, what is this a matter of funding? Is this a cultural, historical thing? What are the factors that are playing into it, and how are we addressing this lack of studies on women now? I mean, we do constitute half of the population. So you think that.
Right. Yep, it's a great question. So I think the cardiovascular disease question is that we don't really understand. Most of the data on biomarkers come from men, from early studies. And so that has been standardized and validated in men who have heart disease. And for a long time, people thought women don't develop heart disease until you're too old. And people used to come with heart disease and they just send home without doing any tests, because this is just you're faking it, those were the response like 20 years ago. So the cardio biomarkers have been extensively studied that women do get heart disease with normal biomarkers. So that cutoff mark, or whatever we are looking for inflammation, is actually not accurately represented in diagnosing cardiovascular disease in women, which means we have to go back to the drawing board again, and we have to find new mechanisms. And how do women react to inflammation? Even low levels of inflammation, you may have risk of developing atherosclerosis, which is going to be a huge concern that we need to look into. I think that's where the research has to be done, and that's because we are skewed by getting all the data from predominantly men who are having heart disease, and so basically we have to do more research on that.
Thank you. So we have 2 minutes left. We'll go by turn. If each of you will take turns to pick the one topic you would like to most like. I know it's very hard to choose when we all see so many issues that need addressing, but it'll be great to hear which one you want to spotlight. Nalini, Amita, Shyam, and Smriti, I'll request you to close out with your topic.
Okay, so let me go first, and I'm probably not going to answer the question exactly, but if I had to close my thoughts today, I would leave all the women, maybe for the men, the women in your lives, tell them, they are making healthcare decisions every day for the family as they cook their meals at the kitchen table. When the family sits down to dinner, there is a healthcare decision being made every day. So I want the women to own, to understand and appreciate that they can steer their families towards healthy living. And that is probably the hardest nut to, it's the holy grail of diabetes prevention, is getting everybody to change behavior. For us, it's the woman who holds the key. And the advice I would have is aaj se thoda kam. So just a little less from today, a little less salt, a little less sugar, and a whole lot more health.
That's great. Thank you.
Amita, can you go next?
Yeah, I mean, as I think about sort of, we've talked about so many things today, but one thing that I think I'm incredibly passionate about, of course, as a professor in a school of public health, really is workforce development and training the next generation of public health leaders. We need a 21st century public health workforce, and that looks very different than the workforce that we've had in the past, and maybe even the workforce that we have today. And so again, thinking about sort of the AI revolution that's upon us already, thinking about both the, sort of traditional diseases that we have been grappling with in the women's health area, as well as new issues that will come to light, whether it's new pandemics or new issues that unravel. I think that we need to ensure that we have a public health workforce that's trained and ready to go, and who truly understands how so many of our health disparities are rooted in gender inequities. And without addressing those gender inequities, we will not flourish in terms of our healthcare interventions and programs.
Fantastic point. Shyam, please.
Sure, I would be short. Like we all know that women make decisions for others. Women make decisions for their parents, for their husbands, for their children, very easy to make. But when it comes to their own health, it's not a priority. We got to change that. That has to be priority. It is part of our culture. We always try to serve others. And particularly women exemplify that in our culture. We have to change that. And that has to be, we have to teach them and help them to understand that they have to prioritize their health.
Thank you. Smriti, please.
I have two things to say, right? I think given my background, the first thing is data. Data is key. We need to find a system that has data integration, interoperability, and we have all stakeholders, right? Different races, women in the equation to make the right decisions at the right time. That starts with clinical research, R&D, product development, till the end point of execution. And the second one is, I know that this is a women's health topic, but we are not going to do it alone without men's support, right? So we need everyone in the system agreeing to it, joining hands, and really making the change across the pipeline. So two hopes for the future.
Thank you all for that fabulous conversation. We have gone 2 minutes over, and I know we have much more to talk, but I'm glad you've got the ball rolling for us. As a practicing doctor, as an NGO leader focusing on healthcare, as a public policy expert, and as a corporate leader helping with healthcare questions, I think you've given us much to think about. And as I said, one of our hopes in bringing the people together and having this also live streamed is to have people leave here not with many answers as much as more questions, because I think that's where we all need to keep reminding ourselves that this is still an issue worthy of a lot of attention and thought and engagement. So thank you all, and Indiaspora is honored to have had this conversation with you guys participating in it. Take care, everyone. Thanks for joining.